We're going to talk about the nursing care of a child with a lower respiratory disorder. We're going to pay attention, if you can, when you're in the clinical space, to the child's age, their socioeconomic status, and their overall health status. It's going to influence the development and the severity of any respiratory illnesses. Keep in mind that tiny ones, infants, are likely to deteriorate more quickly from a respiratory illness, and that makes it really important to be aware of the early cues of worsening respiratory status before the child becomes critical. Asthma is the most common chronic illness of childhood, and it affects over 6 million American kids. That's so many, 6 million. 13 million missed school days, 14.5 million lost work days for parents, and the incidence is only increasing. It increases with urbanization. The more buildings that we have, the more pollution we create. Just the act of building a community, like building houses, when we tear up the ground and it spreads pollutants, and it's going to attack the children's airways. And yeah, we have so much of it. I don't know if you guys have noticed, but around Kern County also, they are required to keep the ground wet when they start to dig to create new building areas, to try to keep the dust and dirt from flying through the air. So increased air pollution is always going to be a precursor to more asthma diagnoses. So our little valley has a lot of asthmatics, and I can go outside, see the kids, 6 or 7 years old, that are out on the playgrounds on a windy day at school or during one of the dust storms. And I know that a large portion of those kids are going to end up in the hospital within the next 3 to 4 days after that dusty windstorm, because of their responsiveness in their airway to those triggers. We also see a ramp up in asthmatic admissions to the hospital after the Kern County Fair, for obvious reasons. And then another thing that has led to the 6 million children being diagnosed with asthma is that literally there's more accurate diagnostic tools now. So we're able to single out the children who actually have asthma versus just an acute attack of allergies. So asthma is a disorder of 3 mechanisms that lead to the chronic inflammatory conditions in the airway. And that's airway hyperresponsiveness, airway edema, and airway mucus production. All of these things occur over time because of repeated asthmatic attacks. So the way I like to think about airway hyperresponsiveness is, let's say you have a child that's, I don't know, tapping on your legs when you're talking to a friend, and they're saying, "Mom, Mom." The first few times they do it, it's annoying, but your response to them is quieter. It's not immediately, "Could you stop it? I'm talking to my friend." In the beginning, our response is normal. And then as it continues, and as that child continues to tap on our legs and ask us and ask us and ask us while we're trying to talk on the phone or talk to a friend, our response inflates. we become hyper responsive to our child, and that's when we're going to snap at them and push their hand away and tell them that they're going to be in trouble if they don't leave us alone. So your airway is kind of doing the same thing with asthma. The first few times it's exposed to the trigger, it just has a normal response that everybody would have. We have a little bit of airway edema, we have a little bit of mucus production, um, but over time, every single time that trigger gets introduced, the airway gets a little bit more angry and it becomes hyper responsive by sending tons of mucus. It remodels itself and creates tons of edema, and it just continues to happen that way. So one of the most important things that we can do with asthma is to decrease the amount of times that a child will have an acute asthma attack. It shouldn't just be, oh, you have asthma, so you're going to have acute attacks and that's how your life's going to be. It needs to be, we attempt to prevent those acute attacks in any way possible so that we can decrease the amount of hyperresponsiveness and remodeling that their airway is going to have. Okay. The cues that we will see in an asthmatic, wheezing, usually an expiratory wheeze, because asthma is a disease of air trapping. So it's not that they can't get air in, it's that they can't get the air out. So we trap the CO2 in the body, and that creates issues. So we'll hear the expiratory wheeze. Cyanosis is possible. With a younger child, we'll see head bobbing with each breath. There's going to be accessory muscle use with intercostal retractions, shoulder shrugging with each breath, tripoding potentially, and nasal flaring. And then we'll also see the child refuse to speak or drink or eat. So because they have to choose which one's more important, talking or breathing, and they're going to choose breathing because who wouldn't? The complications that we're going to see with an asthmatic are that they become more susceptible to serious bacterial and viral infections. They'll develop status asthmaticus, which is an asthma attack that just continues and can't be cracked. And then they can develop respiratory failure. I've given you the top link on this page is to the Wakelet, and there's a good video of how to teach someone to use a peak expiratory flow meter. So the labs that we do for an asthmatic, a pulse oximetry is not really a lab, but it's a diagnostic tool. I don't use it a whole lot. I look at the child more frequently than I do the numbers. Chest x-rays are going to show hyperinflation. Pulmonary function tests is something that is usually done as an outpatient, and it tells you the degree of the disease, the amount of tidal volume and respiratory volumes that your child has, or an adult. The problem with a pulmonary function test done as an outpatient is that the child has to be between like 5 and 6 years old to really understand how to follow the directions to perform the pulmonary function test. So it's not valuable for children that are too young. We also do allergy testing, and that can help to determine what some of their triggers are. But as Kern County, we have so many triggers. And allergy testing is really pretty traumatic, and it almost feels like torture. It's pretty bad. Anybody who's had it knows that it feels horrible. In the management of asthma, we need to look at the control or the prevention of inflammation that's at the core of an asthma attack. So our goal is not to treat an asthma attack. Our goal is to decrease or prevent inflammation. That's our goal. Because if we can decrease the amount of times that a child has an acute asthma attack or prevent them altogether, then we can prevent the hyperinflation, the hyperresponsiveness, and the airway remodeling that they're going to end up having over their lifetime. We need them to avoid their triggers. We need them to use a peak expiratory flow meter, which is this little picture right here. They're going to use it every single day at the same time, every day, and they're going to do 3 forceful breaths and write down the number that the best attempt gave them, the best attempt out of 3. They write down that number every single day, and that's going to guide their home management action plan that is a requirement by the Joint Commission and the Centers for Medicare and Medicaid. They require every child who has a diagnosis of asthma to go home with one of these action plans after every hospitalization. And I'm going to show you that, I think, on the next page. So here's an example of a home management plan of care for an asthmatic. So every single hospital is going to have a slightly different one. The doctors, if you are dealing with new resident physicians, they might not know how to do this. They need to be informed, and you have to check it. You have to go behind your doctor and check that the home management plan of care has been filled out and that it's filled out accurately. So you have to do their job for them, and you have to make sure that they know that it's wrong if it's wrong and that they fix it. So every single patient that has a diagnosis of asthma is going to get one of these when they leave. I always tell parents, give one of these to the school nurse. Have the kid carry a copy of it in their backpack or take a picture of it and keep it on their cell phone. Keep one for the grandparents. Keep one for the babysitter. Stick all of these copies on the fridge where they're in plain view. Cystic fibrosis is an autosomal recessive disorder that's more common in Caucasians. Both parents have to carry the gene, but they don't have to express it. So frequently, children born with cystic fibrosis are born to parents who did not know that they are carrying the gene. It is a dysfunction of the exocrine glands. So everybody typically thinks of cystic fibrosis as a respiratory disease, which it can be, and it is, and that's usually what leads to death. Is basically the lungs are filled up with mucus and secretions and fluid, and the child can't breathe anymore. But because it's a dysfunction of the exocrine glands that causes the increased mucus production and thick mucus, those are things that we have to focus on during treatment, as well as the respiratory system. So their sweat glands produce more chloride. Their GI tract, it has really thick, tenacious secretions. So steatorrhea, which is a clumpy, grody looking, fatty, almost kind of lumpy, frothy, floaty poop. That's what steatorrhea is. It can be a common thing in a patient with cystic fibrosis. Prior to diagnosis, they tend to have a lot of steatorrhea. If we see steatorrhea increasing in a child who already has diagnosis of cystic fibrosis, then our assumption is that they are not taking their pancreatic enzymes with every meal the way that they should be. Their pancreas does not do what it's supposed to do because it is an exocrine gland as well. and there's no enzymatic activity within the pancreas for the cystic fibrosis patient. So they take pancreatic enzymes to replace, and they take them with every single um, time they eat. So when you have like a 7-year-old who eats like a little picky bird all day long, just grazing and grazing and grazing, um, you are constantly in that kid's room giving them pancreatic enzymes. Their airways get plugged with all of the mucus that their body is creating. And you're probably wondering why there's a little salt shaker up in the corner, and I'll tell you in just a second. All right, so cues that occur with the cystic fibrosis patient, and this is the reason for the little salt shaker. Um, like I said, they have frequently steatorrhea. If you hear little growls and grunts, I have 4 puppies running around, so I'm sorry, I can't make them be quiet. So the cues are steatorrhea. They have increased mucus production everywhere. GI tract, respiratory tract, their vaginas, if they're little girls, you might see increased mucus surrounding the tip of the urethra on the penis in a male. They're going to grow poorly. They're going to be short-statured, very thin and sometimes wasted looking, and that rounded appearance of the belly that you see in children with absorption problems and protein deficiencies. Um, they also have what's called a salty kiss, and that was the reason for the little salt shaker. Because they have increased chloride, their sweat glands are kind of malfunctioned. They excrete more chloride through their skin. So parents back in the olden golden days used to know that there was something different with their child when they would give them a kiss on the cheek or kiss their little foreheads, and they just tasted way saltier than your normal sweaty headed little kid. Um, Even their little lips are salty, like tears. So salty kisses is a common cue that we would see in a child with undiagnosed cystic fibrosis. Some of the complications that they can have, and there are a ton, they can suffer from a lot of hemoptysis, from just constant coughing. They call it like paroxysmal coughing, because their body is trying so hard to get the mucus out. They can suffer pneumothorax frequently. They're colonized frequently with bacteria, and these are very uh, nasty bacteria. And each cystic fibrosis patient can be colonized with a different type of bacteria, and that makes them dangerous to each other. So if any of you have ever seen the movie, I think it's called 6 Feet Apart or something like that. I don't remember. It's basically a movie about why 2 cystic fibrosis teenagers who meet each other can't be near each other even though they love each other. So, and that bacterial colonization is the reason for that. They are frequently colonized with a grody bacteria that has, like, maybe one person's grody bacteria has a little hook in its cell wall, and that allows it to hang on to mucousy, slick surfaces. And then someone else's bacteria that's exactly the same grows some cell wall that's able to stick in the mucus. I don't know. So we don't want one child to give their form of the bacteria to another child. So they can't be within 6 feet of each other. Core pulmonale is another thing that they can develop. Volvulus, intussusception, keep that in mind because when we talk about intussusception in the GI system, um, this is I would write a test question about cystic fibrosis patients and intussusception. They frequently have obstructions that lead to rectal prolapses and bowel perforations. It's just bad stuff happening in there. They frequently develop diabetes, although it is diabetes that is not classified as type 1 or type 2. It's specifically related to the failure of the pancreatic enzymes. They also have liver failure. As far as diagnostics are concerned, when we diagnose a patient with cystic fibrosis, we do what's called a sweat chloride test. And the sweat chloride test has to be greater than 60 milliequivalents per liter. So they go in, they have a weird little patch, almost like a 2x2, placed on their arm and covered with Tegaderm, and that little pad collects the sweat, and then that sweat is tested and measured. And that is the definitive diagnostic assay for cystic fibrosis. And then after they have a sweat chloride test that's positive, then they'll usually do genetic testing as well. Management and treatment. First thing we need to do is to minimize any pulmonary complications. We do that by using specific nebulizers. There's one called Pulmozyme that they use frequently. We use bronchodilators, and we use anti-inflammatories. The respiratory therapists will come in a couple times a day. They'll give the bronchodilator and inhaled anti-inflammatories and Pulmozyme, and then they will put the percussion vest on the child and beat them and shake them and beat them and shake them for a little while, and they get to know them really well, and they spend a lot of time in their room, and they're like best friends. So that helps to mobilize the mucus and the secretion so that the child can expectorate it out. Another part of management is preventing infection. So they do have inhaled antibiotics that they use as well as oral antibiotics, and they use them pretty much long term as prophylaxis. We also want to maximize the potential for physical growth in a cystic fibrosis patient because they do tend to be smaller in stature and have some growth and developmental delay because of spending so much time in the hospital and not being able to process the nutrients from their food the way that a normal healthy person does because they have malfunctioned GI tracts. So part of what we do to maximize growth is to give them pancreatic enzymes with basically every time they eat and with snacks. We give them fat-soluble vitamins, not water-soluble vitamins like everybody's used to taking. We give them the fat solubles, and we give them high protein and high caloric content foods. It's also fine for them to have a bit of increased salt in their diet because they're losing a lot of salt through their skin. So we can increase their salts a little bit, increase their protein, increase their fats, increase their caloric intake. They basically can eat a really big, fatty, greasy, high protein meal, and we kind of like that.